Thank you, everybody. Now we are going to the guest lecture session on neurology. To chair the session, I request Professor ShyamalKundu. He is the professor and head medicine, Bankura Sammilani Medical College, and Dr. Ananda Bagchi. He is a vice chairman of API West Bengal branch and also consultant physician from Kolkata. I request Dr. Professor Kundu and Dr. Bagchi, please take the chair and start the proceeding.
Good evening, colleagues. We are going to start a new session on nephrology. I, on behalf of my co-chairs, Professor ShyamalKundu and Dr. Lalit Agarwal, invite Dr. Vivekananda Jha, a noted nephrologist of Mumbai, to deliver his talk on CKD in the community. As you all know, as the prevalence of diabetes is increasing, so incidence of CKD is also increasing. So CKD in the community is really a problem. I will invite Professor Vivekananda Jha to deliver his talk on CKD in the community. Over to Professor Vivekananda Jha.
Thank you very much for your kind invitation and for the introduction. I hope you can see my slides.
Yes.
Right. Thank you. So thank you, Professor Kundu and Dr. Paul and other colleagues. What I'm going to do over the next 20 minutes or so is to talk about how to manage chronic kidney disease in the community and how physicians and nephrologists can work together. So let me just start by telling you this fact, which is well known, but still not talked about a lot, about the treatment of kidney failure in the world. Globally, about 10 million people develop kidney failure and need treatment every year, but only 2.5 million, which is 25 lakh, in comparison to 1 crore who need treatment, receive it. Everyone else, which means almost 75 lakh people who require kidney failure treatment, die. So that means that dialysis is not universally accessible. In India, we did this study many years ago now, and we estimated that every year about 210,000 new persons, which means 2.1 lakh new persons, develop end-stage kidney failure and die without access to dialysis. But you will ask the question, this is only the extreme form of kidney disease. What about less extreme forms of kidney disease? So there were 2 surveys which were published almost 10 to 12 years ago. And the summary of the findings of those survey of adult population, which looked at a non-risk factor based approach and defined chronic kidney disease as estimated glomerular filtration rate of less than 60 mils per minute, and found that the prevalence for that was 4.2% and 8.1% in the 2 studies, whereas proteinuria prevalence was 2.25% if it was done only by dipstick, but if albumin creatinine ratio was looked, it was as high as 11%. We more recently did a study in rural Andhra Pradesh, and where we found that a much greater proportion of people had kidney disease. Almost 42% of the adult population had hypertension, 13% had diabetes, and 21% of this rural population had chronic kidney disease, in which you also had lower than normal filtration fraction, which is eGFR less than 60, and increased proteinuria. What is even more important is that 9 out of every 10 people who were found to have chronic kidney disease in this survey did not know that they had the disease. So which means that there is a large undiagnosed burden of chronic kidney disease in the community. Similarly, this study was done in Punjab by using the WHO STEPS survey. They looked at 2,000 participants. They also found very high hypertension prevalence, similar to what we had found. And in their study, low eGFR was 2%, but albuminuria was quite high, 46%. Unfortunately, there are no community-based data from many other states, including from West Bengal. So we have to go by what is available from these other parts of India. Now, all the physicians are aware that chronic kidney disease is a progressive condition where one starts from normal health and passes through a stage of increased risk to kidney damage, to then kidney injury, which is defined by reduction in estimated glomerular filtration rate. And eventually, when it is still unchecked, eventually the patient may reach the stage of kidney failure and might eventually die. But most of the people in the community, as well as unfortunately physician community, think of kidney disease only when kidney failure sets in. But the fact is that even more patients with early stage chronic kidney disease will die of cardiovascular causes before needing dialysis. So what it means is that a substantial proportion, you can see this in this particular slide. This slide is actually taken from a study done in US, which shows that the age standardized ratio of hypertension in the bottom chart, of cardiovascular events and death altogether goes up as the estimated glomerular filtration rate decreases. And this increase starts at a very, very early stage, even when the GFR is considered to be more or less within normal range, but still lower than normal. In India, most of the people present with chronic kidney disease only when they have developed very advanced kidney failure. So this slide shows you that almost 48%, this is data from all over India, from Indian Chronic Kidney Disease Registry, presented with stage 5 CKD. And this is something which we also confirmed in our study, which we did in PGI many years ago. So what it means is that, as I told you before, that many people would have died undiagnosed in early stages of chronic kidney disease of cardiovascular causes. So therefore, the fact remains that early stage chronic kidney disease is asymptomatic, but early stage chronic kidney disease can also be identified by simple tests. And what are these simple tests? We all know about it, but it is often not ordered for patients who might be benefited. They are serum creatinine and proteinuria testing. But I must caution that it should not be used indiscriminately. It should be ordered only in high-risk populations. So the next question is, who are the people who are at high risk? So these are the people who have diabetes, who have hypertension, who have prior cardiovascular disease, who have family history of kidney disease, and who give a long history of nephrotoxic drug use. And more recently, we have identified some occupational risk factors, which means that these are people who might be working in hot and humid environments for a long period of time. So the fact is that complications of chronic kidney disease can actually be prevented, and CKD progression can be arrested by a few simple things. And these are not drugs, these are non-pharmacological treatments, such as lifestyle changes, maintenance of ideal body weight, by controlling blood pressure, and we recommend blood pressure control of less than 120/80, as was shown in the SPRINT study, by good glycemic management, and we recommend keeping HbA1c to less than 6.5. This is based on the results of the advanced study, and there is evidence that lipid lowering therapy, metabolic control, is also beneficial in preventing complications of early stage kidney disease. But equally important is timely identification of chronic kidney disease complications. And we have data to show that patients with chronic kidney disease are often not screened for cardiovascular diseases. We also need to understand a number of treatment gaps that exist in chronic kidney disease treatment. And these treatment gaps are related to the rapidly changing disease burden of kidney disease. And as I said before, there is a large undiagnosed and untreated population in the community. But unfortunately, we don't have enough nephrology workforce. And what to talk of nephrologists, often physicians are not available in many rural areas. So depending only on physicians to deliver care will perhaps lead to neglect of a large number of patients. We often disproportionately focus on curative care, such as dialysis or kidney transplantation, and we don't focus on prevention, which means that there is a lack of effective organized community-based programs for detection and treatment. And I'm not showing you a lot of data, but there is also evidence to suggest that guideline-based care is often not given to these patients. And what is the guideline-based care? Guidelines have shown, and randomized controlled trials have shown, that chronic kidney disease progression can be prevented and complications can be averted by these simple things. For example, controlling blood pressure, as I said before, in those with high blood pressure, controlling blood sugar in those who have diabetes, lifestyle modification in everyone, including increased physical activity, increased consumption of fruits and vegetables, and vegetarian diet. Non-vegetarian diet is not prohibited, but people should not take excess of meat. For example, every day non-vegetarian diet consumption is perhaps harmful. Then there are a few drugs also which work in people with chronic kidney disease. They include blockade of drugs that block angiotensin pathway, statins, as I said before, and SGLT2 inhibitors. Patients with kidney disease can be monitored very easily using telemedicine approaches. And in telemedicine approaches, we can ask the patients to get some of these equipments at home, which include blood pressure monitor, glucometer, and in COVID, we saw that pulse oximeter and a thermometer were also useful adjuncts, which we asked all our patients with kidney disease to get at home. And they could use their mobile phones to get in touch with their treating physicians or their treating nephrologists. But as I said before, there are not enough nephrologists in the community. So we need to develop partnerships with community physicians, including general physicians and general practitioners. And nephrologists can do a lot to help physician colleagues manage patients with chronic kidney disease in their community. And we can do this by developing a toolkit for early CKD identification and management. We can help develop information materials which can then be shared with public and healthcare providers. And we can work with colleagues in partner professional organizations. All the nephrology organizations can work with organizations such as the West Bengal API chapter and many other similar organizations to improve messaging, implement practice change, monitor outcomes, and develop advocacy tools. One such effort has been made at global level by this organization called the Kidney Disease Improving Global Outcomes, which is the premier organization that develops treatment guidelines. And I had the pleasure of participating in this effort, and which led to this publication, which lays down certain standards for community detection and management of chronic kidney disease. So as I said before, we need to identify who are those at high risk. And I have described some of those before: hypertension, diabetes, cardiovascular disease, family history of kidney disease, those who have had acute kidney injury in the past, those who are obese, and those who are at other high risk of comorbidities and have environmental exposures. How can we screen for kidney disease? By serum creatinine and urine albumin creatinine ratio. And then we need to confirm that these abnormalities are indeed present for 3 months or more, because that is what we require for diagnosing chronic kidney disease. If they are not confirmed, then we need to just tell the patient they don't have kidney disease and ask them to come back after 1 to 2 years. And if they have chronic kidney disease indeed, then we go ahead and do risk stratification. And we then, on the basis of risk stratification, we can take appropriate measures. And these measures can be divided into 3 boxes. The first box is for patient safety, which means that if the patient is on any drug, that those should be adjusted based on EGFR and so on and so forth. I will not go into the details. And other advice can include, for example, prevention of unrestricted consumption of non-steroidal anti-inflammatory agents, use of metformin with close monitoring at 50% dose when the EGFR goes down to 45 or below. And if the EGFR goes down to less than 30, then avoid all NSAIDs altogether, etc., and many other drugs that should be avoided. Then we undertake steps which slow chronic kidney disease progression and reduce complication. Again, treat high blood pressure, treat diabetes, treat chronic kidney disease complications such as anemia, acidosis, and chronic kidney disease, mineral-borne disease. All of these people should be vaccinated for influenza, pneumococcal vaccine, hepatitis B vaccination, and of course now COVID-19 vaccination. And they should all be screened for hepatitis C, and if hepatitis C is present, it can be easily treated. We also undertake CVD risk reduction by controlling blood pressure, lipid lowering therapy, and using aspirin in those who are in whom it is indicated. And appropriate referral to nephrologists when there is either sustained decline in EGFR, or if the EGFR goes to less than 30, or if consistently proteinuria remains high, because these patients may require kidney biopsy and so on. So therefore, my dear friends, I would like to conclude by saying that there is a huge unmet need for care of chronic kidney disease subjects in India. There are large demand-supply gaps. Systematic efforts are needed to get proper data, including data from West Bengal on the prevalence of chronic kidney disease and on the pattern of treatment of chronic kidney disease in the community. We need to recognize that nephrology-centric model of care is unlikely to work because there are just not enough nephrologists. We need to improve our ability to identify those who are at risk of developing chronic kidney disease, and then we must implement smart preventive methods. With this, I will end my presentation. I thank you for your attention, and I'm happy to take any questions.
Thank you, Professor Jha, for your excellent deliberation. The subject is now open for discussion. I will invite one or two questions from the audience.
Am I
If there
audible?
is any question.
Am I
So,
audible?
Professor Jha, I have got a small question. Why the incidence of cardiovascular disease increases as the EGFR decreases? And if there is any cutoff of EGFR where the incidence of cardiovascular disease increases and why?
That's an excellent question. So there are a number of metabolic abnormalities in people with chronic kidney disease, and there is abnormal endothelial cell function, which we have also shown in our studies in people with chronic kidney disease. So if you measure brachial artery vasodilatation in response to vasodilatory stimuli, it is impaired in people with early stage chronic kidney disease. There are lipid abnormalities which give rise to cardiovascular disease. There is impairment of sympathetic function, which is also deleterious for cardiovascular health. And similarly, there are a number of other abnormalities which all taken together increase cardiovascular disease risk in patients with early stage chronic kidney disease. Now, the second part of your question, there is no cutoff. In fact, the cardiovascular disease risk starts increasing even with mild decrements in EGFR. And as I showed you the data from United States, from Kaiser Permanente in California, even people who have EGFR less than 60, but it has come down from the normal value of 90 or above, these people are at increased risk of developing cardiovascular disease. So we must not think of chronic kidney disease as a condition where you can make a diagnosis based on a very strict EGFR cutoff, but it is a progressive condition. For those who have a starting EGFR of 100, even a decline of 20 and bringing it down to 80 will still be considered within the normal range, but they have actually shown a decline from their normal value. Whereas in another person who is relatively small with low body weight, their starting EGFR might be 65 or 70. In that case, they are perfectly healthy even with that EGFR. So we need to follow the EGFR trajectory rather than look at a single EGFR to make treatment decisions.
Excellent, sir. So I
think
yes.
Dr. Kundu was trying to say something.
Professor Jha.
Yes, go ahead.
Thank you, Professor Jha, for excellent deliberation. One question from my side. What do you think of prospect of chronic kidney disease with the advent of dapagliflozin? Few comments.
No, that's a great question. So dapagliflozin has ignited increased interest in a new renopreventive therapy. And in fact, dapagliflozin has now perhaps become primarily a renoprotective agent and cardioprotective agent than a blood sugar lowering agent, right? The latest DAPA-CKD study showed that people who had chronic kidney disease, even those who did not have diabetes and had chronic kidney disease, showed an increased improvement in their outcomes. And this increased improvement in their outcomes was present in people with all types of chronic kidney disease. So this is really a potentially very exciting development. And it is possible that dapagliflozin will be used increasingly in nephrology practice. But we need to do additional clinical trials, especially in patients with non-diabetic chronic kidney disease, primarily by not including people with diabetes. So we have right now put in an application to Indian Council of Medical Research to study dapagliflozin in people who have chronic kidney disease, which is non-diabetic, non-hypertensive as well. We are putting in an application for such a study in kidney transplant recipients. So dapagliflozin is likely to become a standard of care for treatment of chronic kidney disease if it is shown to be effective in these randomized clinical trials.
Professor Jha, is there any evidence that shows DAPA reverses the kidney function, deteriorating kidney function?
Well, not yet. So the first thing to say is that even though DAPA-CKD study was done with dapagliflozin, of course, but so far there is no evidence to suggest that this effect might be limited to dapagliflozin. It is probably a class effect. So all SGLT2 inhibitors likely possess this efficacy. But so far there is no evidence to suggest that any of these agents, whether it is SGLT2 inhibitors or ACE inhibitors, etc., prevent or lead to regression of kidney disease. That does not happen. So the only drug which had at some point been shown to have this was bardoxolone methyl, but unfortunately, randomized clinical trials subsequently showed that it possessed unacceptable cardiovascular side effects. So its use was abandoned. So there is no drug right now which can lead to reversal or regression of chronic kidney disease once it is established.
Dr. Kaur? So if there is no other question, I conclude the session here on my behalf and also on behalf of Professor ShyamalKundu. So thank you very much.
Thank
Good
you.
evening, Dr.